Good afternoon. This is Jacob Rogers, and I'm a fourth-year pharmacy student at Texas Tech University Health Science Center, and I will be presenting a pediatric in-service on febrile neutropenia, discussing the management of febrile neutropenia in a pediatric population. Today we'll discuss the following lecture objectives, mainly touching on what is febrile neutropenia and its general etiology. Then we'll discuss the risk stratification and criteria that determine outpatient versus inpatient management. And then lastly, we'll look at some current guideline recommendations for the management of febrile neutropenia. So a great question is, what exactly is febrile neutropenia? And so there's two different components that we're defining here. For the fever component, this could be either a single temperature of greater than or equal to 101 degrees Fahrenheit, or a sustained temperature of greater than or equal to 100.4 degrees Fahrenheit for at least 1 hour. So this could be either of those two options. And for the neutropenia component, this is an ANC, or an absolute neutrophil count, of less than 500, or a count that's expected to be less than 500 within the next 48 hours. And then just for review's sake, I have the calculation for getting an ANC, which is the white blood cell count times the percentage of neutrophils plus bands. So who is this typically affecting? It's mainly affecting patients that are receiving or have recently received cytotoxic chemotherapy. And I feel like a main distinction to make here is that there is a difference in the risk depending on cancer type. And so patients with some form of hematologic malignancy are going to experience febrile neutropenia to a much greater extent, estimated to be 80% of patients with some type of blood cancer. Whereas patients with solid tumor malignancies have a lower risk of developing febrile neutropenia, more in the 10 to 50% range. So why does it matter that we're concerned about febrile neutropenia? Well, the main concern is that infections tend to be one of the main causes of morbidity and mortality in our cancer patients. And it's really the fever that tends to be the first sign or symptom that these patients are aware of that may be leading to some type of severe infection. It is important to note here that a fever does not always mean a severe infection is present, though. And actually, documented infections in episodes of febrile neutropenia only actually occur in 20 to 30% of the time. And so there are other causes that could lead to a fever in a patient with cancer, either just being a side effect of the medication or just disease progression. And so it's important to note that a fever does not always mean infection, but we need to address it as one and start treatment promptly. So a brief discussion on the etiology. We are considering these to be bacterial most of the time if an infection is present. And so the most common cause or organism that's isolated in the blood is coagulase negative staph. And it is important to note that there are increasing numbers of infections that are due to drug-resistant organisms. Here listed is gram-negative, but then also, as you can see in the chart on the right-hand side, there are gram-positive resistant bugs with methicillin-resistant strains, and then also we have our VRE or vancomycin-resistant enterococcus strains. Something else unique to point out is that fungal infections can occur, but they tend not to occur early in the course of the neutropenia, and it's most commonly seen in those patients once some type of prolonged neutropenia is present, and that's going to impact our therapy recommendations that we will talk about a little bit later on in the presentation. So we'll jump into guideline recommendations, and for our pediatric patients, there was a specific guideline published in 2017 from the International Pediatric Fever and Neutropenia Guideline Panel. And then also for adults, and a couple mentions towards pediatric patients, we have the 2011 Infectious Disease Society of America recommendations. So for initial evaluation, our main component is going to be a risk stratification, and this is typically done based on clinical assessment. There are formal classifications that are done, as is listed at the bottom of the screen here with the Multinational Association for Supportive Care in Cancer scoring system, where a high-risk patient is deemed to have a score less than 21. But most commonly, it's simply done by clinical assessment alone. And so a high-risk patient is deemed to be one that has prolonged and profound neutropenia. This is defined as greater than 7 days duration of an ANC less than 100. This could also be high risk defined by hypotension, pneumonia, or some type of other respiratory difficulty, new onset abdominal pain, or some type of altered mental status or progressive neurological changes. And then for our low risk patients, it's simply going to be the absence of what we just discussed above. Neutropenia expected to last less than or equal to 7 days, or really no other abnormalities present. So this initial evaluation with our risk stratification is important because it's going to determine our treatment setting. So inpatient treatment is going to be recommended for all high-risk patients. It's also going to be recommended for patients that are deemed low risk but have some type of other factor present, namely being the presence or documentation of some type of infection, cardiovascular abnormalities, if they're severe thrombocytopenic with a platelet count of less than 10,000, and then naturally if they're unable to swallow oral medications, that's going to require IV therapy. And then a common thing that we see in pediatric patients being if there's a concern that there would be poor adherence or poor follow-up in the outpatient setting, those patients are going to be recommended to come in initially for IV therapy. So then lastly, outpatient treatment will be recommended for those patients that we know to tolerate oral medication and have the means necessary to have appropriate follow-up. There was a 2019 Cochrane review that was published looking at outpatient versus inpatient treatment, and this is specifically in low-risk patients, and it found that there was no statistically significant difference for treatment failure, mortality, and risk of adverse events in our outpatient versus inpatient management groups. So for initial testing, and this is geared mainly towards our high-risk patients in the inpatient setting, blood cultures are going to be recommended in both central venous catheters and also obtaining a peripheral blood draw, ideally from 2 different anatomical sites. And then a chest x-ray is only going to be recommended in those patients that do present with some type of signs and symptoms indicative of a respiratory tract infection. And then lastly, a urine culture and urine analysis is only going to be recommended in those patients where it's suspected that some type of urinary tract infection could be the cause of the fever. So for initial management, it should be noted that empiric therapy is going to be recommended for all patients, regardless of being high or low risk. And so for our high risk patients, again, these are going to be getting IV therapy. Recommendation is for monotherapy with an anti-pseudomonal beta-lactam. And so that's a little bit broader recommendation than the 2 antibiotics I've listed, but these 2 listed here tend to be commonly used agents. And I'll even say that cefepime is the most commonly used agent for empiric therapy. Here at a dose of 50 milligrams per kilogram per dose, IV Q8 hours. And then meropenem is listed at a dose of 20 milligrams per kilogram per dose. And the asterisk here is simply because literature notes that there are limited data regarding the use of this agent in the pediatric population for this indication, all the while guidelines do recommend that it can be used. And then lastly, this bottom bullet point is just noting that in patients that are clinically unstable or seem to be regressing, a second gram-negative covering agent should be added. Then for our low-risk patients, guidelines are fairly vague, but it is recommended that oral antibiotics can be used if we can trust that they will be taken properly, and that there is the support necessary to have careful follow-up and monitoring. There are no specific oral agents listed, and so for the outpatient regimens, this typically is a fluoroquinolone in combination with augmentin. Now, we do have the concern of using fluoroquinolones in our pediatric population, and so that may limit the use of these oral therapies in that population. And so kind of clinical judgment is what would be recommended for making that distinction for using oral antibiotics in the outpatient setting. So therapy modifications, this is primarily targeting, again, if there is some type of decline in clinical status with a persistent fever, then at that time you would increase and escalate empiric antibiotics depending on what suspected pathogen would be present based on local resistant concerns. So the duration of therapy is going to be a primary concern since this is empiric therapy. And if patients do have negative blood cultures at 48 hours, are afebrile for at least 24 hours, and there is some evidence of bone marrow recovery, meaning an increase in the ANC, then at that time empiric antibiotics can be discontinued. However, if an infection is detected, then it's recommended that that infection is treated according to site and organism specific guidelines. So empiric antifungal therapy is a concern in a select specific group of populations. And this high-risk patient population are those deemed to have AML, some type of high-risk ALL, or a relapsed leukemia. Also, if they have recently had stem cell transplantation or are receiving high-dose corticosteroids, then those are the patients that we are going to be most concerned about for having a fungal rather than bacterial infection. So these high-risk patients, if they do have prolonged febrile neutropenia, and this is slightly different criteria than what was defined earlier, but for the fungal concerns, it's going to be greater than or equal to 96 hours, then we would consider initiation of an antifungal agent, namely caspofungin or liposomal amphotericin B. Again, if they're low risk, then we're going to withhold antifungal therapy. Antibiotic prophylaxis does tend to be a common question that's asked, and this is actually a current research gap in the pediatric population. And so fluoroquinolone prophylaxis is what's recommended in our adult patients if they do have prolonged or profound neutropenia. Again, an ANC less than 100 or for greater than 7 days. And so this quote at the bottom is taken directly from the IDSA guidelines, saying that this really has not been studied in our pediatric population, but for those deemed very high risk, fluoroquinolones can be considered for prophylactic therapy. Lastly, we will move into some self-assessment questions. Question 1, we have which patient below at this present time would be considered to have febrile neutropenia? The correct answer choice here would be answer choice C, persistent temperature of 100.8 and an ANC of 480. Question number 2, prolonged neutropenia is defined as, and profound neutropenia is defined as. This is going to be answer choice D, which is 7 days and an ANC less than or equal to 100. Question number 3, what is an appropriate empiric therapy choice for a high-risk patient with febrile neutropenia? This is going to be answer choice B, cefepime. Question number 4, when should empiric antibiotics be discontinued? This is going to be answer choice E, all of the above. Lastly, if there's any questions, please do not hesitate to reach out and I'd be happy to answer them. Thanks.